Welcome to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of members of Cambridge Neuroscience. Cambridge Neuroscience is currently going through quite a detailed consultation process to develop 6 new themes for the research we do here. Each of the next 12 talks will come from one of the 6 new themes, 2 from each. For more info on the themes and the talks covered in this series, please follow the links below and follow us on Twitter at CamNeuro. Today we welcome Professor Gordon Harold from the Faculty of Education here at Cambridge. Gordon is new to Cambridge and is the inaugural Professor of the Psychology of Education and Mental Health here at the University. He will be speaking to us on Unpacking Nature from Nurture, understanding how family processes affect child and adolescent mental health. Welcome, Gordon.
Well, Dervla, thank you very much. It's nice to be introduced by a fellow Dubliner, or no, a fellow Irish person. You're from, distant land of Galway, not quite Dublin. My first ever. Yeah. Thank you, Dervla, for that introduction. And good afternoon, everybody, and thank you all for taking the time to come along. I know 4 o'clock on any day through Zoom is a challenge, so thank you all for giving your time up late afternoon. So, as Dervla said, my name is Gordon Harold. I'm newly appointed in Cambridge Faculty of Education as Professor of the Psychology of Education and Mental Health. I started formally in Cambridge in July last year. I've actually been to Cambridge only twice. I'm sitting in sunny Cardiff presently, but I hope to meet Cambridge colleagues and other, and actually see Cambridge, I hope, in the coming months, and look forward to my first pint, I hope, in Cambridge in not too distant future. Simon, that one is for you. So my primary research interests, just to give some setting, some heads up really in terms of the focus of the seminar. It's a privilege and somewhat of a rarity for me to speak as part of an event called Cambridge Neuroscience Seminar. So I'm not a neuroscientist, but I hope to at least evidence to you, if not convince you, that the work I conduct by way of research has relevance to the field of neuroscience, and I'd be particularly interested in questions at the end. So my main research interests focus on family relationship influences on child and adolescent mental health. I'm particularly interested in examining the interplay between genetic factors and family environmental factors, but also how we tease apart that interplay, how we identify genetic factors from environmental factors, and then better understand how genetic factors work with environmental factors and vice versa, to better understand children's long-term mental health and development. It's on this topic that I'll try to present some recent research to you over the course of the next 40-45 minutes, and again try to link it to the world of neuroscience as best I can. You can all hear me okay? Yeah, sound is fine. Good. Okay, so I'm going to start by making my own life a little bit easy. I'm going to start by assuming nobody knows anything about the field of child development. And I'll give you a little slide on everything you ever need to know about explaining to your friends, your own children, colleagues, what influences child and adolescent mental health and development. Following that, then focus in on primarily the area of child and adolescent mental health, and specifically family relationship or family factors that are correlates or associated with aspects of child and adolescent mental health. I'm going to introduce a term called process-oriented. In the United States, where I did my PhD, is process-oriented. If you're from the United Kingdom, it's process-orientated, however you want to spell that. But I want to try to integrate 3 domains of relevance. 1, research design, 2, theory, and 3, statistical methods to address a fundamental question. Do children's experience of specific family relationships matter for their mental health and development? If so, how? And if we evidence that such factors do affect child and adolescent mental health, what does that research mean for practice and policy? And how do we translate or convert that research into practice and policy applications? I'm going to focus in terms of my own research and research examples through the presentation on a substantive challenge to any research that involves biologically related individuals, parents, carers, siblings, and others. And that's what's referred to as gene-environment correlation. That is the associations between an aspect of family environment and an index of child and adolescent mental health, which are correlated, may actually just be explained by shared genes. And I want to address that challenge with respect, again, to interpreting findings and converting those findings to practice policy applications. So this is the slide. You can use the slide anytime you want, any cocktail party or any birthday party to explain the fundamentals of child development. Happy for you to use this slide. So this is a young person if you were a first-year undergraduate class or lecture or year in psychology, and I met you, I would come in and put this picture up in front of you. I've done for several years now. And I would suggest, does this young person look happy or unhappy? And I'd use body language to try to coach you to concluding this young person doesn't look very happy. And I would say then, as a psychologist or developmental scientist, we're interested in understanding why this young person isn't particularly happy in this case, and whether or not the behavior he's presenting is what we refer to as typical, understandable and normal, or atypical, deviating from typical behavioral patterns as you might expect in with other individuals of similar age, gender, and influence, etc. So what factors influence variation in child and adolescent development, and in particular this young person's expression, which looks a little bit cross, let's just say? Okay, so what factors affect behavior? Genetic factors. Nature, a lot of evidence, several hundred years worth of evidence around genetic factors. More recently focused on what we refer to as polygenic risk scores, so constellation of genes being associated with specific areas of both typical and atypical development. So genetic factors fundamentally important for understanding variation in human development. Nurture, the first domain of nurture relevance, prenatal factors, exposures during the prenatal period we know are also associated with variation in developmental outcomes. Postnatal factors, classically parenting, so the measure most frequently examined in the context of postnatal environmental factors on children is actually the parent-child relationship, and specifically the mother-child relationship. I'll return to that as I progress through the presentation. Wider family factors, including dynamics between adults themselves, the inter-parental relationship, inter-carer relationship, inter-adult relationship has implications for child and adolescent, again, mental health and development. These single-headed arrows are suggesting that there are causal influences. I want to be really clear, everything I present here is correlational, with the arrows being indicative of inference. But I hope through the research design, statistical methods, and theory, I'll convince you that the arrows may be a little more directional than simply associated. School factors, particularly peer relationship factors, but also school experience, fundamental factor, again, in child and adolescent development, and also long-term, what we refer to life chances, mental health and educational attainment, being the two biggest predictors of adult mental health, welfare, and well-being. Epigenetic processes I won't need to explain, so environmental factors serving as triggers or working with genetic factors to engage DNA methylation and related to processes and developmental outcomes linked to this particular area of science. Each of these areas have their own identified realm of evidence, research expertise, and research focus. When it comes to understanding variation in child and adolescent development and understanding typical to atypical development, of course, none of these factors work in isolation, really important point to make. Rather, they work in concert with each other. So we get a complex cascade of developmental processes that affect the young person's variation relative to others in different features of emotional, physical, social, psychological development. Ultimately, we're interested in how these factors converge to influence brain development. And this young person, in terms of what's going on in his brain, if I give you his story in this moment to better understand his expression. So this young person arrived in Wellington, New Zealand the previous day. On the first daylight hours, went out for a walk with his father, age 3, saw an ice cream cone, an ice cream van, I should say, selling ice cream cones, and asked for an ice cream cone. The father said, no problem. So we got in the queue, got to the top of the queue, took about half an hour. And the father realized he didn't have New Zealand currency. So he had to, despite his best efforts to convince the guy selling the ice cream he would come back, the guy was selling none of it. So I had to go off and get New Zealand currency, come back, get back in the queue, which is no longer, got to the top of the queue, got the ice cream. And just as this young person was about to taste it, his father said, can I take your photograph? So I think the face is more seriously than necessarily unhappy. And we might refer to it as a typically developing feature. Now, if you're an undergraduate student, you would be quickly erasing all the notes that I had guided you to say this person looked like they had conduct disorder and serious behavioral problems just from the first expression. And you realize that it's actually my son, age 3, who's now 20. And the real question is, in terms of those early influences, if indeed his development has been affected across the life course, the lifespan. So in understanding child and adolescent development, we need to recognize that development at certain ages and stages of development are not neat, isolated occurrences, that actually early influences significantly affect later development. And if left unchecked in terms of atypical developmental features, an individual may be on a trajectory for poor mental health and related life course outcomes. So I'm going to focus in the presentation on two of these primary influences on child and adolescent, again, mental health development, the interparental and the parent-child relationships. But I'm going to look at these relationships as they relate to primarily child and adolescent conduct problems, neurodevelopmental problems with ADHD and other problems, including depression, relative to genetic factors. That's an important term. Right from the outset, let me say, and I wouldn't want to conclude at any point through the presentation, do I suggest genetic factors are not important for development? They absolutely are. I'm interested in examining whether we can look at environmental factors, particularly the interparental parent-child relationship influences on children relative to genetic factors, and actually specifically where we remove shared genetic factors from those associations to see if we're left anything in terms of associations. That's the focus. Quick summary in terms of evidence. So in terms of the area of mental health, I mean, mental health is receiving a huge amount of attention, popular press attention, research attention, particularly over the past 12, 14 months through pandemic, multiple reports showing rising rates of mental health problems for children, adolescents, and adults and older ages. Presently, estimates suggest that 1 in 6 children and adolescents, so young children from as young as 2 to 3 up to age 18 is the focus of this particular review. 1 to 6 children and adolescents experience serious mental health problems. 1 in 5 adults, currently it's estimated. In terms of UK costs, 100 billion in the UK annually spent on mental health. And by 2030, it's expected to cost globally $16 trillion. Mental health, specifically depression, as a factor of primary influence in some of these cost models. It's important to point out that these estimates, 100 million and 16 trillion, are estimates that were generated pre-pandemic. So it's highly likely those numbers will be exponentially greater over the coming years. And again, emphasizing the importance of research and implementation of research findings to try to remediate these trajectories. UK rates of depression, anxiety, self-harm, substance misuse, and suicide are among the highest in economically well-off countries, OECD countries, for young people and adolescents. In just last year, October last year, Good Childhood Report located children in the United Kingdom, aged between 10 and 15 years, as doing least well in the indicators of well-being, relative to children of similar age in 24 other countries. And mental health being one domain of well-being, not synonymous with well-being, but one area of well-being. Recent studies show, longitudinal studies show that 75% of serious mental health problems in adulthood are in place before the age of 18 years, with mental health having significant implications for education, health, physical health, and other outcomes, long-term employment, intergenerational transmission patterns, etc. And that again, mental health needs to be understood from a lifespan perspective. What type of problems do we see in young people? So I'm going to focus on the age of about 4 or 5, transition to primary school to age 18, exit from secondary school into university or later life, those who go on to university. So internalizing symptoms of anxiety and depression, externalizing problems, conduct disorder, and neurodevelopmental disorders, ADHD, all constitute areas of psychological functioning, mental health, and well-being. Increasingly, it's recognized that children who do not necessarily present with symptoms that attain clinical disorder, but nonetheless can experience serious deficits in well-being and mental health. So increasingly, the focus is on symptom profiles rather than clinical thresholds in locating the origins and the developmental trajectories linked to particular areas of mental health and functioning. Wider areas of well-being, social competence, relating well to other people, academic problems, doing well in school, behaving well in school, etc. And problems increasingly being reported, physical health problems, substance misuse, homelessness, criminality, and suicidality. Debate still rages a little bit about whether or not problems in childhood and adolescence, mental health problems, are actually rising, or whether it's the higher rates of problems being reported is a product of greater amounts of reporting in those who are identifying mental health problems. Either way, mental health problems are exponentially greater than they have been over a number of years, with multiple studies showing, for example, in the case of self-harm, that rates are definitely increasing, and even more worryingly increasing among particularly young people. A recent report showing 7 to 9-year-olds reporting higher rates of self-harm. So these are serious problems, and they're on the increase. In terms of correlates, so the 2 reports, the Good Childhood Report and multiple previous reports, specifically focusing on the UK, focusing on child and adolescent mental health. Family factors are repeatedly identified, family peer factors, increasingly the digital world, identified as factors that are seen to be correlates of a range of mental health problems for young people. I'll come back to genetic factors, as I mentioned earlier, but in terms of evidence over the past 30, 40 years, longitudinal studies looking at aspects of family life and how those indicators of family life affect child and adolescent mental health. The following list is a summative list, not by no means exhaustive. So economic disadvantage, economic stress, we know economic pressure directly affects child and adolescent mental health. Importantly, not just economic circumstances marked by poverty, but actually households that are just about managing, to use the more recent term. So day-to-day challenges trying to maintain economic welfare and well-being. It's associated with outcomes for children. Adult parent mental health, parent with depression, antisocial behaviors, elevated rates of related problems again in children. Parenting behavior practices, so classically attachment theory, parenting style, authoritarian, authoritative, permissive parenting practices, authoritarian, do as I ask and don't ask why. Authoritative parenting practices, do as I ask and here's why. And permissive, do as you want and don't really mind if you ask why. With authoritarian and permissive being associated with poor outcomes, again, for children and adolescents. The relationship between adults themselves, historically examined in the context of parental separation, divorce, parents living together, not living together, and domestic violence, adults being direct victims of violence, children being direct victims of violence, but children also witnessing violence but not being direct victims of violence is associated with poor outcomes in terms of developmental areas of developmental well-being, particularly mental health. The interparental conflict is an area that I'll focus on. The phrase is now used, the realm of silence to violence, to focus on dynamics between adults that serve as correlates for poor outcomes for children. So adults who don't necessarily engage in overtly hostile behaviors toward each other, but don't evidence any warmth or positivity towards each other, right the way through to the more extreme forms of overt behaviors. Both ends of that spectrum are associated with adverse outcomes for children. Classically, parental separation and divorce, and it wasn't that long ago that it was espoused by an eminent politician that the reason for the rising rates of conduct problems in England in particular, was because of the proportion of single parent families. So it was held still that family type was causal with respect to outcomes for children. And we now know that actually it's less to do with the family type and more to do with the family dynamic. Well-functioning single parent households, children can do very well. Levels of conflict that precede, occur during, and follow on from divorce explain more about children's adaptation than an event itself. So actually working with separating couples, working with children to understand processes significantly remediates the effects of parental separation on children, and actually children can do fine. Each of these factors serve as correlates to any one or more of the developmental outcomes I've mentioned previously, internalizing, externalizing, social competence, etc. It's also important to recognize or to point out that when it comes to mental health, understanding mental health processes specific to young people's welfare, well-being, that when we talk about mental health, we rarely talk about single indicators of mental health dysfunction. We've got single areas of mental health disorder, depression, conduct disorder, ADHD, etc. But actually anxiety, depression may precede conduct problems, may precede social competence challenges, academic problems, physical health, substance misuse, criminality, homelessness, and suicidality. So we refer to developmental cascades increasingly when we refer to child and adolescent mental health. Early symptoms without relevant support and intervention, progressing to other problems, ultimately progressing to more severe problems, ultimately leading to clinical diagnosis. Likewise, some of the familial factors linked to those outcomes. Increasingly, it's recognized that these are not factors that occur in isolation, and that rather than focus on correlates, we need to understand processes and mechanisms so as to more accurately identify which factors mediate, moderate, explain why certain influences are associated with particular outcomes for children, and importantly, what we can then do by way of intervention. So I want to introduce a framework. This is what's called a process-oriented framework, family stress model. This was developed by Rand Conger, my PhD supervisor, working with a large sample of families in economic transition in the late 1980s, early 1990s in the state of Iowa, where it was recognized that moving from a certain form of farming, animal-based farming, to crop-based farming, would have significant implications for economic welfare for multiple households. And that based on work from the 1930s, children of the Great Depression led by a guy called Glenn Elder, it was the children of Great Depression being evidenced, children of parents who went through the Great Depression, being evidenced to have significantly greater problems over the following decades. The state of Iowa set up an intervention project with the objective of supporting children whose parents were going through economic change so as to improve not just outcomes for children in terms of their present age, but also intergenerationally. Those children who then would go on to become parents would hopefully be protected from that change process. These researchers show that when it comes to economic stress or pressure, there are multiple adverse outcomes for children. These are some of the outcomes that studies have shown, longitudinal studies have shown. So disrupted sleep patterns, important for early brain development, early behavioral problems, reduced academic problems, and the area that I focus most of my research, the top set of images is child and adolescent depression, both among females and girls, boys, and also the intergenerational transmission of depression from parents to children and children to their next generation of offspring. These researchers said, okay, economic stress being a factor, but actually when we include adult mental health, so now rather than adult mental health being the simple correlate or economic stress being a simple correlate, but that economic pressure serves as an influence on child and adolescent outcomes via paternal and maternal depression symptoms, i.e. stress increases depression for males and females who are parents. The direct association between economic stress and child outcomes goes away. So we refer to this as a mediator, a statistical mediator, but also a theoretical mediator. So the mechanism through which economic stress appears to affect child outcomes is via maternal and paternal depression, which would make sense, mood associated with child and adolescent outcomes. However, when they then introduced another variable, parent-child conflict, such that economic stress, when it affects heightened rates of adult mental health, specifically depression, there are elevated observed measures of adverse parent-child interactions, more authoritarian parenting and more permissive parenting, less authoritative parenting associated with child outcomes, particularly child conduct problems. Last but not least, this study was among the very first to actually look at a factor called interparental conflict, which is a term anyone who works in my group would know well, which actually is looking at the dynamic between adults, not in a divorced or separated context, but in an intact context, and actually how early stress, economic stress, affects mental health, which in turn affects the quality of the relationship between adults themselves, as reported by them and as observed in observational studies, where heightened rates of frequent, intense, and poorly resolved exchanges between adults both affect children directly, but actually affect the quality of the parent-child relationship. So children report more negative parent-child relationship interactions in the context of interparental conflict, which in turn affects child and adolescent outcomes. And actually intervention studies have shown that where interventions target the parent-child relationship with the objective of informing outcomes for children, but where there are high levels of conflict between parents, the effects of those parent-child intervention programs are less likely to result in sustained effects. So researchers began to examine this set of relationships. What happens when the dynamic between adults, between parents, is challenged by early familial experiences, stress, mental health? What does that mean for the parent-child relationship? What does that mean for child outcomes? And how do we better understand those processes to try to develop interventions that improve outcomes for children? I want to focus on the associations between interparental conflict, parent-child conflict, and child outcomes. I just want to introduce you to a figure, just by way of example. It's a complex figure, but hopefully it'll translate into making a point. So those three variables, each of themselves associated, I want to expand further. And in another study, this is actually a study using a UK sample of adolescent children having just transitioned to secondary school, actually in South Wales, where we measured maternal depressive symptoms, paternal depressive symptoms. From the earlier model, you can see paternal, maternal depression, etc. Where you have early child behavior problems, age 11, age 13. That means we're going to try to explain changes in child behavior problems over time. And we show in the UK study that actually maternal and paternal depressive symptoms do indeed predict higher rates of interparental conflict in intact households, community-based settings, so non-high risk settings, just everyday community households. But that actually that association is explained, is amplified when mothers and fathers, and these are intact households, husbands and wives, report greater relationship insecurity with their partner. So where depression leads to a sense of greater relationship insecurity with their partner, spouse, there's heightened levels of interparental conflict. Interestingly, interparental conflict is not associated with child behavior problems directly until you include parenting. So where high levels of interparental conflict affect child behavior, it's because of dysregulated mother-child relationship problems and dysregulated father-child relationship problems, and particularly authoritarian-based parenting, angry, aggressive, inconsistent parenting practices source from interparental conflict affecting child behavior problems. Okay, so this figure utilizes a longitudinal study assessed across 3 years, just over 300 early adolescent children, employs a statistical technique known as structural equation modeling, which allows me to look at that, what looks like a plate of spaghetti, and try to make sense from the various strands and balls and squares, etc., to suggest that where high levels of maternal paternal depression are present and elevated rates of relationship insecurity, there's heightened levels of interparental conflict, frequent, intense, and poorly resolved, which adversely affect maternal and paternal parenting practices, which in turn affect child behavior problems. So we have a series of mechanisms that would suggest actually targeting the interparental relationship relative to child outcome may reduce parent-child problems and ultimately improve levels or presentation of such problems among children. This is a single statistical equation for anyone who's got statistical fluency. Traditionally, we would need to have this decomposed into a whole array of what are called regression equations, conducted separately. This is a single simultaneous estimation, allowing an integration of what's called factor analysis and path analysis, and allows that complex set of pathways and processes to be examined, so that we have a so-called causal model with correlational data to try to make sense, some organizational sense, of the various influences that operate to affect children. Why? To try to more reliably inform interventions that target those mechanisms to try to ultimately reduce adverse effects over time on child outcomes. I'm going to put the next slide up really by way of giving myself, hopefully gaining a bit of street cred among the neuroscience world. So just to say that as this particular paper I worked on in 2001, 2002 in terms of the data, and just by way of timing and discussing this type of model, and I'm a developmental psychologist and in the faculty of psychology, therefore, and I've set my neuroscience colleagues, I wouldn't be very high in the pecking order in terms of proper science. I say that because you'll know that actually a good friend of mine and colleague, John Eggleton, who probably need no introduction to neuroscientists here, is also a very capable runner. So I know this is being recorded and hopefully John will see this. And during my early days at Cardiff University in the School of Psychology as a lecturer, I had the privilege of working with Professor John Eggleton and running with Professor John Eggleton. So, you know, I'd be seen going out for runs with John Eggleton, which gave me a lot of credibility among the neuroscience crew. And while out running one day with John and describing this particular model that I put up just a second, and genuinely specifying that particular theoretical model and talking about parenting and talking about such things. And John was very concerned about what this meant for his own children and what lessons could he take away, et cetera, et cetera. Discussing the actual model and a question he was grappling with at that time, we spoke about the potential benefits of using a structural equation modeling approach to examining the links between perirhinal cortex, postrhinal cortex, and the subiculum. And you'll see a little graph, a little path model to the left, bottom left of that screen, showing essentially what's called the simplex model, which is measures of variation in rat brain through surgery that John did, I had no part in. And we ran a structural equation model, and I, published a paper, and I've got therefore a paper in experimental brain research with John Eggleton. So if anyone says, why are you developmentalists speaking to us? Well, there's a slide with a few brains for you just to convince you that I've got a little bit of credibility. Okay, I want to return to this, the main part of the presentation, but I want to return to this figure. So this theoretical model is now serving as a quite significant policy relevant statement that economic stress affects adult mental health, maternal and paternal mental health. I want to make an important observation here as well. This early work, this early family stress model was late 1980s, early 1990s. For any theoretical model to look at paternal depression in the context of maternal depression simultaneously was quite innovative. So to highlight that both males and females can experience mental health challenges, which in turn affect relationship dynamics, which in turn affect parenting, not just the mother-child relationship, but the father-child relationship and child outcome, back in the early 1990s was quite a revolutionary proposal. This model now has over 30 years of sustained evidence that actually with correct interventions, targeting family processes in the context of economic disadvantage, we show significant improvements for child and adolescent mental health outcomes, particularly important in the context of pandemic, or indeed Brexit, when it comes to economic change. So I put up a complex model a second ago. That actual, again, a model similar to that, when presented at a conference in the US early 2000s, I was asked a question. The question was, given the framework you've just presented, Gordon, and you're looking at family processes, etc., and you're suggesting that, for example, parenting practices, adverse parenting practices, negative parenting practices are associated with, for example, conduct problems. There's a challenge there, and that is that the association that you're presenting, the vast majority of studies looking at these types of questions involve biologically related parents and children. And as a result, any association between biologically related parents and children may be explained by shared genes, specifically what's called passive gene environment correlation. I was asked that question before I really understood what passive gene environment correlation was. I was trained in the group that I was a PhD student around Congar in Midwest United States, in the area of family socialization, where nurture was the be all and end all. And if you mentioned genes in my research group and you weren't referring to denim, you were told to go off and stand in a corner. So I had to go off and study the area of behavioral genetics, and my colleague Anita Thapper bears all credit for anything and everything I now know, Nick O'Donovan and others, in the area of behavioral genetics. But I spent a period of time trying to understand that challenge. And actually, it's a sort of substantive challenge, that if we're going to make assertions about aspects of rearing environment when it comes to domains of child and adolescent mental health and the significance of rearing environment nurture, we need to better understand whether or not those associations are indeed present, whether or not children are genetically related to parents, carers, or not. So I'm going to try to take that question on, and I did when I was asked that question back in 2000, 2001. I literally said, how do you take that question on? And in trying to take that question on, one fundamental facility, research design. Ultimately, if I can test that model you see above you, at the top part of the slide, I should say, not above you, on the top part of my slide, where I'm working with a group of rearing parents and children who are not genetically related, that would allow me to contest the assertion that the association is only present where parents and children are genetically related, or only significant because they are genetically related. So I want to try to partition G, nature, from E, nurture, to identify whether those associations remain significant. No amount of fancy statistics, by the way, will ever allow you to do that. You can only do that through research design. Again, just by way of summary, not two distinct, but two complementary areas of genetically informed studies over the past number of decades. So molecular genetics, people, again, will need no introduction, but molecular genetics has a bit of a new dawn in recent years, where the arrival of polygenic risk scores are allowing a little more precision around specificity of particular phenotypes. This is a paper with my colleague Mick O'Donovan I gave credit to Mick, and a Cardiff group using a longitudinal study in New Zealand, the Christchurch Health and Development Study, looking specifically at polygenic risk scores for schizophrenia, and showing that at age 9 and age 11, for those individuals who possess particular polygenic risk scores for schizophrenia, significant differences exist in areas of mental health, primarily in the area of anxiety, generalized anxiety disorder. As a developmentalist, anxiety age 9, 11 might be seen to be typical entry into and progression through puberty, to suggest that actually significant differences exist in anxiety for those who hold a polygenic risk score for schizophrenia is an important window in terms of potential interventions and support with respect to that particular developmental outcome. Prior to the advent of molecular genetics, the approach towards to identifying relative genetic effects versus environmental effects is what are called quantitative behavioral genetic research designs. I'm going to come back to this paper in a second. This slide is really a kind of landscape summary slide of types of designs that historically are located in the realm of quantitative behavioral genetics. And the designs in blue are really the more historical. So a twin design, monozygotic, dizygotic twins, and sibling design, siblings to different relative genetic relatedness, allows us to identify relative genetic similarity and dissimilarity, and tests of concordance between twins, for instance, relative to specific life event exposures and the like, allows us to identify whether monozygotic or dizygotic twins are more similar or less similar based on genetic factors, etc. Estimates of genetic relatedness and associations with so-called heritability estimates prospectively. The adoption design and the IVF design I put in yellow, you'll go back to this slide to have a look at it. But I want to clarify that these are new arrivals on this landscape, rather than historically being seen to be quantitative behavior genetics type designs. I'll explain why in a second. So why? So we go back to this figure. I've boxed off the interparental, the parent, child, and the child developmental focus specifically because policy interest has been occupied for many years, particularly in the last few years, as to where do you support families? Where do you support parents more specifically when it comes to supporting child and adolescent mental health and development? Do you support the parent-child relationship? Do you support aspects of the adult relationship? Do you support children? Where do you target interventions? So it's with that question that I want to ask the question. If it's the case that parent-child, for example, parenting practices, parent-child neglect, parent-child authoritarian parenting practices, permissive parenting practices, etc., are associated with child and adolescent developmental outcomes. And that association might be explained by what are called shared genes. Passive gene environment correlation is exactly that, and an association between an aspect of the rearing environment and child outcome, child mental health, is because of shared genes. Passive gene environment correlation. If I take the arrow, child problems to parent-child neglect, and turn it the other way around, that's asserting that actually a child's genetic makeup may evoke the rearing environments that they experience. It's called evocative gene environment correlation. Do you get that? Helen, I'm looking at you, Helen, so you're going to have to nod for the entire group, so you get that. So passive gene correlation is explained by shared genes, evocative gene environment correlation. You turn the arrow around and genetic attributes in the child evoke rearing experiences. That's a particularly challenging assertion. The direction of effects is turned the other way around. I'm a parent of 2 children. I'm happy to say they absolutely evoke responses every day of the week. The question is, who's evoking whom in terms of relative influences longitudinally and over time? Where do you target your support? So I want to introduce 2 studies that will endeavor to take on that question. The first, and going back to this slide, adoption design, is a study in the United States led by my colleague Leslie Lev. I'm a collaborator on the project. It was in part founded David Rees and colleagues, part founded by my colleague Zhao Jaga, who's unfortunately passed away, but is a significant intellectual contributor to both the designs you're about to hear about. Adoption design is unique in that clearly children and rearing parents, where there's no degree of relatedness, relative links, are not genetically related. In the UK or other parts of the world, the process through which children receive, or a family receives, what's called a legal order, placement, adoption, can be several years. So actually lag time to adoption actually is a factor itself in understanding factors that might affect child and adolescent outcomes. So there's a study in the United States called the Early Growth and Development Study, which is the largest adoption study of its kind in the world. Uniquely, it's an adoption study involving just over 500 children, all of whom are adopted at birth. So 2.5-day lag time to placement, so quite unique in terms of its design features. The study has both clinical interview and importantly, DNA sweeps of all biological parents, including a subset of fathers, all adoptive parents, and children. Children are now going into their 17th year. So it's a unique longitudinal study. The second study, an IVF study, was set up in the United Kingdom, myself and my colleague Anita Thapper, in the context of IVF, where gametes are inherited, if you like, that actually where sperm, for example, is adopted, the rearing father would not be genetically related to offspring. And I had that conversation 5 times to convince myself that that was correct. But actually, true in the context of in vitro fertilization, you've got 5 unique groups. Homologous IVF, parents and children are genetically related. Sperm donation, fathers not related. Egg donation, mothers not related. Embryo donation, and surrogacy. And uniquely, you can have a group of rearing parents and children who are not genetically related, but where adoption occurs at conception. So we have 2 unique adoption designs, one at conception, one at birth, and hence these two designs fall onto the landscape of quantitative behavioral genetics, but uniquely, compared to sibling and twin, there are no shared genes between rearing parents and children. There are unique susceptibility genes, but there are no shared genes between rearing parents and children. Okay? So I can now examine, if you look at that boxed set of associations there, the question as to whether interparental conflict affects parent-child processes, affects child outcomes, whether children and rearing parents are genetically related or not, to ascertain whether associations remain significant. I'll go through this quickly because I'm conscious of time here. I'll be finished in 7 to 8 minutes. This is a study using both the IVF, the UK study, H, and the US adoption sample. The orange coefficients of the IVF H homologous, i.e. parents and children are genetically related. And the blue coefficients, US adoption, parents and children are not genetically related. And if you just look at the mother-child hostility and mother-related child conduct problems, the association is practically exactly the same. The difference between the blue coefficient and the orange coefficient is shared genes cannot explain that association. Passive gene environment correlation is not present in that correlation. You see that? Rarely studied, father-child relationship and father-reported conduct problems. Same pattern of associations, significant for both. You might say that mothers reporting on their relationship with their sons and daughters and also conduct problems may have what's called self-report or method variance, so we cross over the reporters, do something fancy. This is all structural equation modeling again. And no matter how you try to look at that, associations between intraparental, mother-child parenting, father-child parenting, and child outcome are significant whether you're genetically related or not. And therefore, passive gene environment correlation can't explain those associations. See that? Okay. So that study takes on the challenge of passive gene environment correlation, but not evocative gene environment correlation. We haven't turned the arrows the other way around. This study does that. This again is using just the US adoption sample. This is looking at child impulsive behaviors and the association to child ADHD symptoms. Lag time of 1.5 years. So child impulsive behaviors when children are 4.5 years and children's ADHD symptoms when they are 6. And actually ADHD symptoms is associated with aspects of academic application. And we show that when we have measures of early academic attainment in children age 4.5, again in this US sample, that actually ADHD symptoms associated with deficits in children's mathematical ability versus reading ability. Importantly, controlling for early impulsive behaviors, a correlate or early predictor of ADHD symptoms. This is an important part. So what's the next contribution, next step? So this brings in adoptive mother and adoptive father parenting, genetically unrelated adoptive mothers and adoptive fathers, in association with child ADHD symptoms, genetically unrelated children, and further associations with academic outcomes. This is showing that the rearing environment among genetically unrelated parents is associated with ADHD symptom severity, in turn associated with child maths aptitude. There's no genetic relatedness here. Okay? Passive gene environment correlation can't explain the effects. In this study, as I mentioned earlier, we have clinical measures in DNA from birth mothers. So this particular measure is an assessment of birth mother ADHD symptoms assessed 3 times when children are 6 months, 18 months, and 24 months in the mothers, not in the children, in the mothers. Children are adopted away at birth. The association between birth mother ADHD symptoms and child impulsive behavior can only be biologically and predominantly genetic. You see that? You could draw a line between birth mother ADHD and child impulsive behavior straight down. There is no there's no environmental overlap, only a genetic overlap, partly prenatal, but predominantly genetic overlap between birth mothers and child impulsive behavior. And this is the real fancy part. If you watch child impulsive behavior to parenting and we assess that, we find that that pathway is significant, that child impulsive behavior sourced from birth mother ADHD symptoms evokes more negative maternal and paternal parenting. So elevated impulsive behaviors in children evokes more negative parenting, or challenged parenting, which is associated with heightened ADHD symptoms, which in turn affects maths aptitude in schools. Measures are biological, separated from family environment, separated from school environment. 3 separate sets of influences examined in one model, showing very clear processes to outcome. But importantly, targeting that actually, if we're focusing on resilient parenting, resilient to adverse evoked effects, we may actually affect ADHD symptoms concurrently and maths aptitude longitudinally. There's the coefficients for the stats people in the room. I won't spend any time on this. I'm going to leave this with you just to summarize, but I'm conscious of time. So the nature of nurture, what was I trying to do? So do environments matter? This is a raging debate still. I'm very happy to take questions. Do environments matter? Yes, environments matter. The study designs, both longitudinal in terms of measures, but study designs in terms of being able to uncouple shared genetic effects or factors from environmental factors, allows us to conclude that aspects of the interparental, the parent-child relationships, both mother and father parent-child relationships, significantly affect children's mental health and development. These papers are recent papers to back up some of these assertions. That said, rates of anxiety, depression, conduct problems, academic problems, substance misuse, psychosis, self-harm, and suicidality are all on the increase. And the studies I've summarized have all looked at, with the exception of suicidality, other than a foster care study, where interventions targeted very specifically promoting adaptive foster carer and teenage girl relations with a very specific program, showing a 100% drop in suicide ideation over the course of 5 years among teenage girls, an environmental factor among genetically unrelated carers and children. Family environments, parents, and parenting matters. This was brought home to me in a presentation probably 10 years or so ago now, where I spoke at a community event, and having presented this research, a mother came up to me, a parent came up to me and said that she had been an adoptive parent. And based on this research, this was an event that followed on from a presentation about 6 months prior to that. Based on the research she'd witnessed, she had read it, and it was the first time she felt that her parenting mattered. That everything she read suggested that actually biological factors probably explain more about her son's behavior than her parenting. I hadn't grasped that it was important to communicate such findings with respect to bottom line communities, parents, carers, and others. In terms of communicating findings, the importance of a multidisciplinary perspective speaks for itself. The fact that you've got a neuroscientist and a developmental scientist going out running together and developing structural equation modeling to look at the perirhinal, post-rhinal cortex tells you that in and of itself. But to take this research by way of complex question, complex research design, complex method, and to try to convert into policy and practice, fundamentally requires a multidisciplinary perspective. Based on this research, UK interests moved to looking at interventions that promote positive interparental and parent-child relationships, and can we evidence positive impacts for child and adolescent mental health. An initiative in the United Kingdom called the Reducing Parental Conflict Programme, which was launched in 2017, is in part based on this and complementary research, with the fundamental objective of trying to interrupt intergenerational cycles of adverse interpersonal conflict, breaking down adverse conflict dynamics between adults, carers, impacts on children with a view to those children going on for future relationship experiences. This is the program you see 18 January 2021 and 6th of April 2021, so very recent. So just over £60 million has been invested in this program. It's been through multiple reviews, evaluations. I'm regularly pinned to the wall by policymakers around evidence and other academics around evidence. But this program has just been renewed for another year. Core focus is actually shifting practice models for those at the front line, job centers, other contexts working with disadvantaged families, specifically around not just measuring mental health in certain contexts, focusing on child and adolescent, but actually improving the communities that those frontline practice groups work with. For example, disadvantaged families, parents at economic risk, parents experiencing mental health problems. How do you work with adults, carers in a way that promotes more positive outcomes for children without directly working with the children? And the most recent example is only the past number of months, big focus on mental health in schools. Increasingly, the interest is moving away from just measuring prevalence rates of mental health problems in schools We're looking at correlates of mental health children who present with mental health problems in schools, and actually looking at the interface between family processes, parenting, child and adolescent presentation in schools, and the role of mental health, and how working across those overlapping areas might actually promote more positive outcomes for children and young people. That's it. I finished. I hope that was okay. I actually finished in time.
Thank you for that wonderful talk, Gordon, and welcome to Cambridge. We look forward to fruitful future collaborations with you. Join us next week when we welcome Roger Barker, Professor of Clinical Neuroscience here at the University of Cambridge and consultant neurologist at the Addenbrooke's Hospital. His research seeks to better define the clinical heterogeneity of two common neurodegenerative disorders of the central nervous system, namely Parkinson's disease and Huntington's disease. He will be asking the question, can we repair the Parkinsonian brain? For more info on this seminar series and all things neuro-related here in Cambridge, follow us on Twitter at CamNeuro and follow the links below. See you next time.